Okay, so let's see, thumbs up for those who are on, if you can see the slides. Looks good. Okay, great. All right, so yes, thank you for inviting me today to give this talk to the HIV Institute. And as mentioned, I want to share some of the work that I've been doing for about the past 4 years here in Southern California with our American Indian population. And the title of my talk, Nobody Really Talks About Any of It, is a quote that's taken from one of the more recent studies that's currently underway. But as I said, for the past 4 years, there's been a couple of projects that I've been conducting that have all provided a better picture of what's going on here in Southern California when it comes to the HIV epidemic and HIV prevention efforts for our American Indian population. But before I jump into those studies, I want to first start off this talk by describing the population of American Indians as well as Alaska Natives here in the United States, where this population is located geographically, some of the demographic characteristics of this group, as well as the HIV epidemic, and how all that information set the backdrop for motivating the 3 studies I'll be presenting later on in this hour. So in terms of the population, American Indians and Alaska Natives represent less than 2% of the United States population, or 5.2 million individuals. And this map here shows the distribution of the American Indian and Alaska Native population across the 50 states. With the states that are color-coded in orange, representing the areas that have the lowest population of American Indians and Alaska Natives, and then all the way up to the states color coded in turquoise, representing those states with the highest count, or in this case, more than 100,000 individuals self-identifying as American Indian and Alaska Natives. So California is the state that has the largest population of American Indians and Alaska Natives. In the 2010 census, there were over 720,000 individuals who self-identified with this group, and that represents about 14% of all natives in the country residing here in California. And how the census has defined American Indians and Alaska Natives is as follows. A person having origins in any of the original peoples of North and South America, this includes Central America, as well as a person who maintains tribal affiliation or community attachments. And so I really want to highlight this idea of tribal affiliation because first, American Indian and Alaska Native is more than just a racial classification. It's a political designation. And that political designation a result of treaties between tribes and the US government. But then also with the tribal affiliation, I want to acknowledge the diversity with American Indians and Alaska Natives when it comes to tribal affiliation. Currently, there's 574 federally recognized tribes within the United States, and this number grows even larger if we are to consider tribes that are recognized by states, but not by federal governments. But it's a highly heterogeneous group representing different languages, cultures, belief systems, tribal government structures, as well as population sizes. It was mentioned in the introduction that I'm an enrolled member of the Navajo Nation. I'm also part Hopi, and I mention this because these are 2 tribes that are located in northern Arizona. My maternal grandfather is Navajo, and my maternal grandmother is Hopi. And Hopis and Navajos spoke different languages. So my grandparents spoke different languages from each other. Hopis and Navajos have different cultures and ceremonies and belief systems. Tribal government and tribal constitutions are different between the Navajos and Hopis, including policies around tribal enrollment. From the 2010 census, Navajos or individuals who self-identified as Navajos were over 300,000. But for individuals self-identifying as Hopis in the 2010 census was less than 20,000. So there's a lot of diversity when we talk about the American Indian and Alaska Native population, and that diversity driven by these different tribes that are here within the United States. But despite having a lot of differences, tribes are united by this history of colonization with the arrival of Europeans to the continent. as well as this history of forced assimilation where culture systems as well as languages were lost, a history of oppression, racism, and trauma, and that these histories have contributed to present day health conditions that we're seeing with a lot of our tribal communities. Another common feature about the American Indian and Alaska Native population, regardless of tribal affiliation, is that most do not reside on a reservation or on their tribal lands. So in 2010, over 3/4 of the American Indian and Alaska Natives lived outside of reservations, mostly in urban populations, but often traveled back to reservations for family, ceremonies, or other events occurring within their tribal homelands. So where is the population mostly concentrated? Again, urban areas. This is a map here displaying some metropolitan areas across the United States. Similar to that map that we saw for just the states alone, this map indicates metropolitan areas that have a low presence, indicated by the yellow dots, all the way up to a high presence, indicated by the turquoise dots, of people who not only identify as self-identify as American Indian or Alaska Native, but they also identify with at least one federally recognized tribe. So we see not too many of these turquoise dots, turquoise indicating more than 50,000 residents self-identifying with at least one tribe. But they're located here in the Phoenix region of Arizona, in the Tulsa region of Oklahoma, as well as here in Southern California in the Los Angeles region. And then notice just adjacent, this captures San Bernardino as well as San Diego, two other regions that also have a high representation of our urban Native population. In addition to showing geographically where the American Indian Alaska Native population is situated, I also want to highlight the demographic composition of this group, in that they have endured unique socioeconomic conditions that have increased the risk for adverse health outcomes. And so what I mean by that is that American Indians and Alaska Natives tend to be younger than the general US population, a median age of 29 years versus 37 years in the general population. A greater proportion live in female-headed households compared to the general population. A lower proportion have graduated from high school, again, compared to the general US population. And then there's higher poverty rates within the American Indian Alaska Native population, and these socioeconomic conditions just contributing to poor health outcomes. In regard to the HIV epidemic, this is a graphic from the CDC displaying the rates of HIV diagnoses amongst adults and adolescents over a 4-year period, stratified by race ethnicity. And so what we see in this graph is that the rates of HIV diagnoses have remained stable or decreased for most racial ethnic groups. With American Indians and Alaska Natives, we can see that line here in green, between 2014 and 2016, there is an increase in infections, and then those infections start to come down thereafter, where rates in 2018 are starting to look similar to what we were seeing in 2014. But overall, when we look at the most current data, which is from 2018, what we're seeing is that American Indians and Alaska Natives account for less than 1% of all new diagnoses. And remember, I said earlier, this is a population that accounts for less than 2% of the overall population. So small population size, as well as not a lot of infections. But what we are seeing with this group is a high HIV-related disparities occurring. Here's a graphic showing diagnoses amongst American Indians and Alaska Natives from 2010 to 2017. And in that surveillance data, what we know is that there was a 39% increase in the annual number of new HIV infections during this period, where most of that increase was being driven by young to middle-aged American Indians and Alaska Natives, as well as by males. The other factor contributing to HIV-related disparities is that Natives are more likely to have an undiagnosed infection. So this is some statistics that were pulled from the 2017 surveillance data, but in that data, it was shown that 24% of American Indians who were infected were unaware of their HIV infection status. Compare this to 16% of the general US population who are infected living with an undiagnosed infection. And then the other item contributing to HIV disparities within this group is elevated rates of sexually transmitted infections. So here are two data or two figures showing the rates of chlamydia and gonorrhea in the United States according to 2018 STI surveillance data. And for both men and women, American Indians and Alaska Natives have the second highest rate of chlamydia, and they also had the second highest rate of gonorrhea. And we know this to be concerning because the same behaviors that drive STI infections are the same risky sexual behaviors that can drive HIV risk, meaning more sexual partners, unprotected sex, not knowing the infection status of your sexual partners. And then there's other factors that increase risk amongst American Indians and Alaska Natives. And so here are some of those outlined here. First, being stigma, just a lot of stigma around addressing or discussing anything about one's sexual health, as well as one's sexuality. And I'll discuss a bit more of this when I jump into some of the studies that I've been conducting here in Southern California. There's also issues around confidentiality, concerns about having people know that you're getting tested for HIV or engaging in any type of HIV prevention-related education. There's high alcohol and illicit drug use that occur within American Indians and Alaska Natives. Research has shown that Natives tend to use at a younger age as well as in greater quantities in the general US population. The fourth item just being the lack of culturally appropriate programs, that this idea that one size fits all doesn't work, particularly when we're talking about a group that has 574 tribes within this country. And that's just federally recognized tribes. It gets even more heterogeneous when we include state recognized tribes. So trying to identify prevention programs that would resonate within these very diverse tribal groups. And then lastly, data limitations. This is a huge barrier, particularly with our surveillance systems when it comes to trying to identify the burden of infections within the American Indian Alaska Native population, but yet knowing that from research there have been documented instances of racial misclassification. And so this leads to underfunding when trying to target services specific to American Indians and Alaska Natives if there's an undercount of how many people are actually dealing with HIV infection. And all of this information, you know, of looking at the HIV epidemic within the American Indian and Alaska Native have been addressed by our federal agencies. This first screenshot I'm showing you is a work plan that was developed by Indian Health Services over a decade ago. And Indian Health Services is a federal program within the Department of Health and Human Services, and it exists to provide health care to individuals of federally recognized tribes. And so Indian Health Services put together this work plan to identify ways to mobilize resources around addressing the HIV epidemic within the American Indian and Alaska Native population. And in this work plan, there were concepts such as building capacity, identifying ways to integrate HIV prevention messaging within existing health promotion programs that Indian Health Services had going on. As well as looking at things such as HIV treatment and how to better monitor and evaluate the HIV epidemic within the American Indian Alaska Native population. Not long after this report came out, another report came out, which was from the Center for Disease Control and Prevention. And this report was more focused on improving surveillance efforts and looking at ways of capturing the burden of HIV within small populations with a focus on American Indians and Alaska Natives. And so within this report, there were discussions around how do we improve or how do we minimize racial misclassification. But there are other things that were mentioned, such as improving routine testing of American Indians and Alaska Natives, of getting data on HIV infection rates back to tribes or to organizations serving American Indians and Alaska Natives. So it was really against this backdrop of knowing that these reports existed, that federal programs were looking and focusing on American Indians and Alaska Natives when it came to the HIV epidemic, that motivated the 3 studies that I've been conducting here in Southern California with this population. And so these 3 studies each built off of each other. As I learned a little bit more, I added some more questions as we do in science, and that led on to the next study. And so the first study was a purely ecological, population-based study that was looking at geographic accessibility to HIV services. And after conducting that study, that led to a second study, which was to try to address some of the aggregation bias that could occur when doing these types of ecological analyses. And the second study was to use individual level data to look at HIV testing patterns and see how those results supported or didn't support what I was seeing in that first study in terms of geographic accessibility to HIV services. And the third study, which is currently underway, builds off these other 2 studies, and that it's a cross-sectional mixed methods study that's being conducted in collaboration with some of our tribal reservations to identify local level prevention priorities that tribes have when it comes to HIV and STIs. So I'll go ahead and explain each of these studies and what I found from each and how one builds off of the other to provide a better understanding of what's happening here in Southern California. So the first study was motivated from knowing that a lot of the tribal reservations in the United States are located in rural regions of the US. And that surveillance data was showing that there have been an increase in HIV incidence for our rural regions, but not a lot of testing. That testing capacity remains low within rural sections of our country. And so the goal here with this study was to examine the geographic accessibility to HIV testing and medical care for the American Indian Alaska Native population. And so this was done through a spatial analysis, where at first the analysis was to look at drive time or travel time to reach services at the census tract level, and then compare these travel times to the population density of American Indians and Alaska Natives here in San Diego County. And another part of this study was also to look at some non-spatial characteristics, including clinic attributes. And what about those clinics were similar or dissimilar from other clinics in the county, and meaning the clinics that were serving or within American Indian Alaska Native areas. So here's a map displaying descriptively some of the results that came out of this first study. The areas outlined in blue indicate the American Indian reservations here in San Diego County, of which there are 18 federally recognized tribes. And then you'll notice there are some green squares here. The green squares are the HIV testing locations in our county that were identified from the website hiv.org. This is a limited representation of testing sites because it doesn't include personal doctors' offices, for example. And then there's this blue color gradation representing the drive time to reach these services. So light blue, less than 5 minutes, medium blue, 5 to 10 minutes, and dark blue, between 10 to 15 minutes. And then any areas outside of this color gradation indicating areas where it takes longer than 15 minutes to reach these services. So just looking at this map, we see that for at least our tribal reservation communities here in the county, that a lot of them are located in regions where it's taking 15 minutes or longer to reach these services. And when we looked at the clinics that were nearby the Indian reservations here in the county, we were noticing some differences in terms of the type of services that were offered compared to other clinics within the county. And those differences being that clinics near reservations were less likely to offer free HIV testing. They were also less likely to have extended business hours compared to other clinics in the county that would have hours on Saturdays or hours after 5 p.m. on the weekdays. And then lastly, what we were seeing is that clinics near reservations were less likely to offer HIV care within that clinic network. So that if a person tested positive at that clinic, they would have to go elsewhere to seek treatment services in the county. In terms of looking at this relationship, the spatial relationship between travel time and the density of American Indian Alaska Native population, we conducted what's called a spatial regression analysis to look at the average drive time relative to the population density of American Indians and Alaska Natives, while controlling for factors that included the number of people living with HIV per 10,000 residents and the proportion of the population between the ages of 25 to 44 years. And so what this analysis allowed us to do was to generate regression coefficients that varied spatially across census tracts. So here, this map on the left is showing San Diego County subdivided into census tracts where the different color gradation represents the regression coefficients that came out of this analysis, where the regression coefficients are measuring this association between travel time as well as the density of American Indians and Alaska Natives. And in this graph, the way to interpret this is that for these light blue and dark blue regions, that the average drive time to HIV testing increased as little as 1 minute to as much as almost 35 minutes for every 50 American Indians and Alaska Native residents per 1,000 residents within a census tract's population. This map over here is a map displaying which of these census tracts had a significant relationship between drive time as well as the concentration or presence of American Indians and Alaska Natives. And so a lot of these areas that are significant are also census tracts that overlap with areas that have American Indian and Alaska Native reservations. So what we were seeing with this first study is that the capacity for delivering testing was suboptimal in our county where we have a larger presence of American Indian and Alaska Natives, particularly in sections of our county where we have our tribal reservations. But we also know that these are sections of our county that tend to be more remote, more rural, where there are just not a lot of services out there. So the second study was focused on looking at individual level testing patterns and seeing if those results supported what we were seeing with the testing capacity of our tribal reservation areas. And part of this study was motivated by surveillance data again. And this study focused on women, and it focused on women because 2016 surveillance data showed that American Indian and Alaska Native women had accounted for 24% of HIV diagnoses amongst all American Indians, whereas in the general population, women comprise 19% of HIV diagnoses. So for this study, I worked with Susan Little and her group performing a secondary analysis of a retrospective cohort study that she had going on amongst women who were participating in a community-based, voluntary, and confidential HIV testing program. And this was the Good to Go program that's out of the ABRC that in which we acquired data from 2008 to 2018. Here is some of the bivariate associations that we found from conducting this secondary analysis of that data set. First, what I want to highlight is where the women were coming from in this cohort study. A similar proportion of Native women and non-Native women describe their residents as being rural. And we looked at rural. Rural was primarily sections in our East County where women were coming from. But there wasn't a difference here in terms of rural residents. Also with sexual profile or sexual risk profile, we weren't seeing a difference there either between Native women and non-Native women. So a similar percentage in both groups had reported always using condoms. A similar percentage in both groups reported having multiple sexual partners, and a higher percentage of Native women reported a history of STIs, but that wasn't statistically significant. Where we did see differences, though, is here in having a previous history of an HIV test. For women living in rural regions of our county, we saw that Native women were less likely than non-Native women to have a previous HIV test prior to enrolling in this voluntary HIV testing program, there being over a 20 percentage point difference. And similarly, even for urban women, we are seeing a difference between Native and non-Native women having that previous HIV test, but the difference not being as drastic as it was for rural women. So what we were seeing in this study supported some of the findings from that first study, in that it was the rural Native women least likely to have an HIV test. And from that first study, also knowing it was our tribal reservations that are primarily in the rural regions of our county had very suboptimal access to HIV testing as well as HIV care. And so at the time that I was working on these two projects, this study came out through public health reports that further highlighted some of the things that I was seeing here locally in San Diego County. One, which I've already mentioned before, is that there was this increase in HIV infection rates. This paper itself was looking at a different time frame of 2005 to 2014. But in this paper, they're seeing that increase being driven by men, as well as people between the ages of 15 to 54, so our young to middle-aged American Indian Alaska Native adults. And so this led the authors to conclude, that certain groups, such as 20 to 50-year-olds, 54-year-olds, as well as men, would benefit from having increased HIV prevention and screening efforts. And the third point that I wanted to highlight is that the authors made is that some individuals in certain regions that have higher rates of infection would benefit from additional services. And this just this mirroring what we see with the Ending the HIV Epidemic initiative of focusing our efforts in areas that have the greatest burden of HIV infection. But it's the second part that I found interesting that leads into the third study, and that being that in remote settings in which additional services should also be targeted to remote settings in which reported HIV numbers are low. So there's remote settings being where a lot of our tribal reservations are at. And even though HIV numbers may be low, it may be a reflection of just not enough testing going on in those areas, such as we've seen with that second study, and women not reporting a prior history of testing, Native women not reporting a prior history of testing that are coming out of the rural regions of our county. Here's a slide here describing the Ending the HIV initiative, with a map displaying the counties in the United States that have the highest burden of HIV. I want to highlight our Southern California region, which includes San Diego, Riverside, and San Bernardino County, because these are geographic hotspots for HIV infection, but also these are areas that have a large representation of American Indians and Alaskan Natives. When we look at our tribal reservations, there's 33 federally recognized tribes within this Southern California region. And so it's within this framework that this third study was initiated. And so this is a study titled Addressing HIV/STI Awareness and Prevention Through a Community-Based Assessment Among Rural American Indians. It's a 4-year study. We're currently in our 3rd year. And it involves a multi-site collaboration among UCSD, Cal State San Marcos, and then our Southern California American Indian tribal community partners. And we titled this study Shaping Native Health, where shaping stands for STI and HIV awareness and prevention. The goal of this study is to conduct a mixed methods cross-sectional study where we want to identify the local level priorities within our Southern California reservation communities for creating resources and services to address HIV prevention as well as treatment. And we're doing this through the following 4 aims. The first is looking at risk perception at the community level when it comes to HIV and STIs. And then the second is looking at various platforms that currently exist within our tribal community partners' clinics or just within their organizations for delivering HIV and STI prevention education. The third aim of this study is to assess the individual and social structural conditions that are affecting knowledge, attitudes, and behaviors around HIV and STIs. And then the last aim is to identify the local level infrastructure and resources that are needed to implement prevention efforts. And it's interesting because this fourth aim is we're collecting data during a period of a pandemic, and some of you may have experienced this yourself in doing community-based work. But with a lot of our tribal partners, they're rolling out virtual platforms to mitigate any risk with COVID-19. And so now we're in a situation where we're trying to collect data to figure out, first of all, is there sustainability with those virtual platforms? And if there is there any room to integrate HIV prevention efforts within those platforms? So if time allows, I would like to hear what others may be doing with their community organizations as resources are changing or resources delivery is changing with the pandemic. But going back to the study itself, the study is being, again, conducted with some of our Southern California tribes, and these are all reservation communities. And the communities themselves cover a population of over 5,000 tribal members. The tribes that we're working with are located in regions of Southern California that have had high rates of chlamydia and gonorrhea. And they're also located in regions of Southern California that have low population density. So these are in more semi-rural, rural regions of the Southern California. They're also in places that don't have a lot of transportation options. So there's not a lot of public transport going on in these regions. And in terms of getting to clinics, which primarily would be tribal clinics, there's a large distance when it comes to between tribes reaching those tribal clinics. In terms of the data, I mentioned that this is a mixed method study. So we're collecting both qualitative data and quantitative data in this 4-year study. For the qualitative data, it's really focused on getting opinions from tribal community members about what's happening within their tribes when it comes to HIV awareness and prevention. And this qualitative data is being collected in the form of key informant interviews of community leaders, tribal elders, and community members, as well as focus group discussions. And then the second piece of our data is the quantitative data, which is focused on obtaining personal experiences. So not so much what people think is going on in the community, but more what's happening within their own life. And this is through the collection of anonymous behavioral health surveys with 300 community members. And in these surveys, we're assessing their knowledge, attitudes, and behaviors when it comes to HIV and STI risk. So where we stand right now with the data, we've gotten halfway through with the qualitative data, and that's some of the information I'll present to you today. And then we're about 20% of the way through with our survey data. We rolled out our survey this spring, but that happened during the pandemic. So we've had some bumps in the road with recruitment there. So again, I'll just present to you some of our qualitative findings, and this comes from 25 interviews that we've conducted so far through our key informants. And with those qualitative interviews, there were 4 main narratives that came out from those discussions. And those narratives centered around intergenerational and historical trauma, HIV and STI related stigma. There was a lot of discussion around misperception of risk and lack of awareness. And then the fourth theme that came out of these interviews was a discussion around mistrust and privacy. So in terms of historical trauma, a lot of people were talking about how historical trauma had implications on current health conditions of the tribes that we are working with. And one way that it came out is how colonization had an impact on individuals' connection to their culture, and how colonization also introduced this concept of shame that hadn't existed beforehand within their culture. Here's this one quote from a participant that said, and the boarding schools did a really good job at, bringing on the rest of the shame that we didn't have. And we didn't even have a word for shame in our language, prior. So I think that's a huge role in where we're at here, 300 years later. Another common theme that we heard with our interviews was about gossip and being judged. And if a community member was willing to engage in anything tied to HIV or STI prevention or educational related. Here's one person that said, I think there's maybe a stigma with HIV. A lot of people know about it, but they're not really too familiar about it. Or if they have it, you won't really know, or you'll hear someone, hey, they might have that. And so a lot of hearsay, small community, word gets around. Yeah, what's pertaining to each case. I don't know what it could be kind of prohibits somebody from reaching out, but it's definitely like a stigma, being ashamed, not wanting to, I don't know, being judged. Another person said, I don't think anybody ever feels comfortable because that's an admission of something that you might have done or reckless behavior. Participants also thought that HIV was a problem of the past. It's not something that tribal members had to worry about. This person said, I think for the community, it's not on their minds because you don't hear it, they don't see it, they haven't heard HIV/AIDS since the 90s. So people might be under the impression that it's been cured. And then we heard a lot around privacy and mistrust. One person saying, but I think they're reluctant to come in if they know that they're going to see somebody they know. So sometimes it's because of our own families may not get the services that they normally would, because I might be checking you in the front desk. That might be a barrier, or to get my HIV medication from my cousin who works in the pharmacy. And then there is another person, which I thought this was interesting, talking about how the clinicians aren't willing to bring up these discussions when it comes to sexual health. So as patients, we're always told to be advocates on our own behalf, but this particular participant was highlighting how it should be the clinician who's initiating these discussions rather than the patient. And what this person said is, and I feel a lot of times people who do go, seek preventative care or whatever, I don't think that's good enough. I think there needs to be more with that, because not all of it, I don't know. I just feel like there's stuff that is sometimes left out by doctors or physicians. And then I just want to share some other qualitative findings that are beyond those 4 narratives that I initially started off with, because we were collecting qualitative data during the period of the pandemic. And so what we started to notice is a shift in some of the responses that we're getting from our participants. And a lot of this is a reflection of just what was happening in the community due to mitigating risk with COVID. And so first thing, which isn't surprising, we heard a lot about disruption to services and resources, that there's too much testing and hoops to jump through just for regular checkups and things. We also heard a lot about how younger adults were taking the pandemic seriously, and they described some people who just really didn't care and what they call going for broke when it came to partying and sexual behaviors. There was a lot of mention of sex being used as a distraction, as well as the pandemic stress leading to bad decisions. One person mentioned something that was called COVID hookups, that people within these tribal communities were engaging in sex with people who they normally would not have had sex with outside of this pandemic. And then there was a lot of mention around substance use, that there were, during the pandemic, a lot of kids and adults were using substances as an unhealthy distraction, that people were bored, there's a lot of isolation going on, and then also concern around relapses, that people weren't able to connect with services and relapsing when it comes to their substance use. And I share these qualitative findings that we're seeing more recently during the pandemic because it's things that we've seen nationally, right? So there's been reports of testing for STIs and testing for HIV going down across the US. And so what's happening in our tribal communities is just mirroring what we're seeing at a national level with services being disrupted because of this pandemic, as well as what we're seeing with that qualitative data of behaviors changing in response to the pandemic. So I gave you a lot of information of these 3 studies, and I want to summarize some of the implications or some of what I've learned so far with our Southern California tribes when it comes to HIV prevention. The first is that there's a lot of structural barriers, limited testing services as shown within that first study of looking at testing capacity relative to the American Indian Alaska Native population in the county. Also, that sexual risk behaviors don't necessarily explain differences in testing patterns, as we saw with that second study. And then remoteness, sparse populations, and geographic isolation, that these being conditions that further hinder HIV prevention efforts with our tribal communities. And then with a third study, really highlighting these interpersonal barriers that are happening on reservations in Southern California. That there being a lot of talk around stigma related to HIV and STIs, privacy concerns, and a lot of these privacy concerns being partially attributed to being in locations that are remote and geographically isolated, and a lack of awareness, and that all these interpersonal barriers are situated within this context of historical trauma that are contributing to current health conditions. Because we did hear a lot of mentions from our interviews of discussions around boarding schools, around culture and languages being lost, around colonization, and how all of those have an implication for substance use, sexual risk-taking, and mental health that were being seen within the tribal communities. And then I also want to just highlight some of the challenges that I've seen with conducting these 3 studies. And the first is data issues. I'm a biostatistician by training. That last study, I presented some qualitative work that was from a colleague or a co-investigator on this study. But one thing that is huge here with working with a Native population is a lot of data issues. First, with small population sizes and the suppression of small numbers when it comes to studies. But the need to figure out, how best to represent tribes, yet have enough data there to tell a story of what's going on. The issue of racial misclassification I've mentioned before, as well as collapsing of racial categories. This collapsing of racial categories is something that was commonly mentioned with our interviews of participants, tribal members that worked within tribal organizations or tribal clinics, that they often were upset by the fact that local level statistics would omit American Indians and Alaska Natives, or if they did include them, they were included in that other category. So nothing really meaningful that could come out of that data. And then third, this need to have data collection tools that are culturally and locally appropriate. The studies I've been conducting here in Southern California, as I mentioned before, there's 33 federally recognized tribes, but it would be a disservice to try to lump all those tribes into one without acknowledging that some measures collected in one tribe may not resonate in another tribe. And then the second challenge that really came out with these 3 studies is the need for culturally adapted interventions. One of the statistics I shared earlier of where HIV infections are increasing with the young versus young all the way up to middle-aged adults, there's really a need for developing interventions, not only for youth, but then also for adults. Working with our Southern California tribal partners, we heard a lot around tribes wanting interventions specifically for adolescents because of sexual risk that occurs earlier on in age. But knowing that surveillance data, that we also have middle-aged natives that are also at high risk, and the need for intervention specific to that population also need to be developed. The other point is having interventions that are focused on a strength-based approach rather than a deficit-based approach. There's a lot of great things that I've learned so far from working with our Southern California tribes, particularly when it comes to family and culture connectedness, and looking at developing interventions around that framework that really highlights the strengths and the resiliencies of our tribes. And then lastly, recognizing tribal diversity and not taking this approach of one size fits all, but developing interventions that are culturally responsive to those tribes. So with that, I'd like to thank you for your time and acknowledge our funders, who has been the National Institutes of Health for these projects, as well as our Southern California tribes and my co-investigators here at UCSD and Cal State San Marcos, as well as study participants and research staff. So with that, I'll go ahead and open it up for questions. I think we're doing good on time. Let's see. Can't tell if there's questions coming through the chat box or what the structure was.
I have a question.
Yes.
This is Madi. Thank you very much for this excellent presentation and the work that you and your collaborators are doing. And my question is related to since I'm border health researcher, I had to ask something about whether the Kumeyaay Nation or whether other groups are impacted in the border context with either HIV or sexually transmitted infections.
Yeah, so we haven't explored whether our tribes along the border are impacted in terms of sexual health. What we are hearing, though, is a lot of substance use and how that's impacting substance use behaviors with some of our tribes. I won't speak about which tribes specifically, just to preserve confidentiality and not shed any negative light on a certain tribe. But what we have been hearing, and this is common throughout Southern California right now, is a lot of overdose fatalities. We're seeing part of that is tied to the pandemic with a lot of isolation and reduced service accessibility. But whether that's unique to border tribes versus other tribes, I won't really get into to preserve that confidentiality, but we are hearing that throughout the tribal communities.
Of course, and I think that's shared with other marginalized or communities with limited access to resources. And thank you very much for your work.
Thank you. And if there are questions that came through the chat, I apologize. I don't know how to access that. So if you could go ahead and just hop on and ask. Oh.
Hi, my name is Paula Nieto Wayo. I'm a clinical social worker at UCSD Mother-Child Adolescent HIV program. Great presentation, and I just wanted to know if now with the pandemic, have you guys switched over to any virtual platforms in being able to engage your clients?
Yeah, so we are, in terms of data collection, we are using virtual platforms. So in addition to call or telephone interviews, we're rolling out our survey through Qualtrics. But of course, that leaves out a good chunk of the population that we would like to get who may not be as comfortable utilizing these virtual platforms, so who may not want to do an interview over the phone, or who may not know how to or want to take a survey online. So it has limited who we're able to include in our study. But then on the flip side, the other thing that we're starting to think about is with these virtual platforms, for example, telehealth, telemedicine being rolled out with some of our tribal clinics, starting to think about, how much longevity, how much sustainability is there with these virtual platforms, and is there any room to start integrating HIV prevention? We've heard with our interviewees from our qualitative data that privacy and confidentiality are two big barriers to any engagement in HIV prevention or HIV screening, that we're trying to figure out if we can integrate HIV prevention services within telehealth, and what will that look like, and how can the tribe start to accommodate that services in addition to everything else that they're currently delivering through telehealth modalities.
Great, thank you so much. I know for our agency, we have seen an increased amount of people engaged back into care due to fear of becoming sick and not knowing what resources to have available. And with that, we've had the opportunity to kind of engage them more virtually. So I just wanted to see if that's been something that's worked out for you guys as well. But it sounds
Yeah, that's data that we're going to start collecting. So we have modified our interview probe to start asking people about whether they've utilized these new virtual platforms and their comfort level with it, and if they would continue utilizing it. So have they done telehealth, telemedicine? There's also been some mobile clinics that have started to roll out with our tribal partners. And so also looking at whether or not community members feel that's something that they're comfortable with, and is another point for us to integrate services. Well, I thank everyone for your time on this Friday afternoon. I know it's pretty late, and it's been a long week with not such great news of a potential shutdown again in our county. So thank you for your time. My email address is here if you'd like to follow up with any questions. But again, thank you for listening, hearing some of the work that's going on with our Native populations. I'm glad to see the attendance, and I see that there's other people interested in what's happening within this group, which is often overlooked. Thank you.